Welcome this evening to the Fit for Menopause webinar on strategies to support your health, presented to us by Wendy Hancock, registered physiotherapist. So Wendy, I'm going to let you take that away.
Thank you, Miriam. So my name is Wendy Hancock. I'm a registered physiotherapist. I've been one for almost 19 years now, and I've been a pelvic health physio for the past 8 years. And of course, we have Miriam.
Hello, everyone. And I'm moderating today, and we'll be here to answer or help to not answer questions, but to make sure that the questions get given to Wendy. I'm also a registered physiotherapist and co-owner of Fit for Life Physiotherapy, and this is now, I think I'm entering my 28th year as a physiotherapist, which is hard to imagine how time flies, but yes,
Amazing.
That's me.
Great. All right. So this is our plan for today. First thing I'd like to discuss are what the goals are of today's webinar. And then I'd like to launch into talking about the different terminology that is used to talk about the menopause transition. So perimenopause, menopause, and postmenopause. Then we'll launch into a discussion about the changes that take place in perimenopause and then in postmenopause. And we'll finish off with developing an action plan of what you can do to support your health. All right. Nothing in life is to be feared. It is to be understood. Now is the time to understand more so that we may fear less. And I thought that this was just a perfect way to embark on this conversation about the menopause transition, because there is a lot of fear associated with menopause, and some of it is because a lack of knowledge. We don't have all the information that we need in order to go through this stage of life successfully. So what I'm hoping to do here today is to perhaps fill some gaps in that knowledge so that you can be empowered, so that you do know what you have control over, what you can do. So to start off, I just want to identify some of the fears that are associated with the menopause transition. And I really want to invite you all to write in the chat, what sort of things have come up for you? Like, what sort of things have you heard about can happen during the menopause transition? What experiences maybe have you experienced yourself? What symptoms have you had? Or Miriam, maybe you can even tell us, like, what have you heard people express to you that maybe they were afraid about, or they heard, or they were going through?
Certainly sleep is a big one that I hear women talk about, is just the struggle with sleep and not being able to get enough, and how it just kind of seemed to change overnight, of being a really great sleeper to all of a sudden not being able to at all. And I think, the change in body composition, like it just seems to change. You do the same things that you've always done, you're eating well, you're exercising well, but somehow your body still changes and, hard to figure out, what to do, right?
Those are two of the biggest ones for sure. And I think that the change in the body composition or change in weight is a big driver for people going through this menopause transition to want to then make changes. And so you want to be wise about how you make those changes. Now, I think we have perhaps a comment here in the...
Yeah, I was just going to say, someone's comment, weight gain, trouble sleeping, and thinning hair. So
that's interesting. Okay. I'm going to show you some of the ones that I came up with. So hot flashes is one we hear about. Not everyone experiences them, but
someone just commented on that as well. Yeah.
Right. And sometimes they are the root of the sleep problems for some people, right? And the night sweats, brain fog. Now, I'm going to tell you, I am in the trenches there with you. If you're in perimenopause right now, I'm there with you. And that brain fog is real. The poor sleep.
100%.
Right?
I'm in post, and I sort of feel like there's times where I just don't remember what the heck I was doing.
Right? Yeah. And I mean, I can't remember my Apple ID password, but I'll tell you what, I can remember my phone number from when I was 6 years old. So there you go.
Yes.
Now, poor sleep, we've talked about heavy or crampy periods, low libido. We talked about the weight changes, headaches. Sometimes migraines become more frequent in this perimenopause time period, vaginal dryness, body aches, depression, anxiety, or just low mood, menorrhage. If you talk to my husband, he will tell you that he's seen signs. Low bone mass, fatigue, perhaps painful intercourse, heart palpitations, breast tenderness. There's a whole bunch of things. And so, like, I mean, no wonder there's fear, right? Now, there is the other side of this as well, okay? There is some good news in the menopause transition. And I do want to say that I don't want to discount any of those signs or symptoms. And there are things that you can do for many of them. But let's talk about some of the good things about this midlife transition. So at this point in our life, especially if we've had children earlier, we might be at a stage where they don't need us constant supervision anymore, right? Perhaps we have a little bit more increased freedom. Perhaps we have a little bit more time or opportunity for exploration. Maybe we have better knowledge of ourselves. Maybe we even have better self-confidence because of that. Maybe we have increased experience. Maybe that has led to career advancement. And I mean, let's be honest here, once we get through that perimenopause, no more periods. Like, come on now. I'll be happy for that. Now, many women actually report their highest levels of happiness after they move through menopause. So there are things to look forward to here. Okay, so the goals for tonight is I want to help increase your knowledge about the menopause transition. Number one, to help foster self-compassion. I want you to understand why these things are happening to you so that you can let go of any sort of feelings of like, I've done something wrong, or this is my fault, right? I want you to have compassion for what you are going through and perhaps what other women around you are going through. And I also want to help use that knowledge to help promote wise action. So I'd like you to understand the process so you can then find the right combination of supports for you. Okay. Now, like I said before, there's a number of terms used to describe the menopause transition. And so I made this little graphic to try to give some clarity to what's going on here. But as you can see, it's a little messy. So I want to start.
Because perimenopause is messy, right?
It is messy, yes. Let's start with at the very top, final menstrual period. So FMP there, okay? I'm going to tell you that on average, that happens around age 51, but of course it can be a few years before, a few years after, but the average age is about age 51. Now, let's go a year forward from there. That's where I've got the star for menopause. And why would that be? Like, why wouldn't we just say, well, menopause is at that final menstrual period? Can you think why, Miriam?
Well, there could be just some change. I mean, maybe you do get another period somewhere in there.
Well, this is just it. You have no idea it's your final menstrual period until 12 months have passed and you haven't had a period. So, I feel like we should at least get an email at that one that 1 year mark saying, hooray, welcome to menopause. And maybe if you have the right app, like tracking your period, maybe you do get that email. I don't know. But the idea is that, yes, menopause probably, really starts at that final menstrual period, but you have no idea that that was your final menstrual period until a year later. Okay. So perimenopause is the time period kind of from where menopause is, that star, going back almost 15 years. It can be variable, okay? For some people, maybe it's only going to be 5 years that you're really in that perimenopause timetable where hormones are really changing. But for some women, this could start 15 years earlier. This could start for some women in their mid-30s, right? And
I don't think women in their 30s think about that at all.
I don't think they
I
do,
never did.
right? Yeah. So, and it's not that for all women it will, but I'll tell you, once you're in your 40s, there is a very good chance you are in perimenopause. Okay. Now, after that star where I've got menopause, that's the whole rest of your life. You are in postmenopause for now the rest of your life. So menopause is a snapshot in time. Okay. It's that moment that, okay, I've been 12 months without a period. Yep. This is really menopause. Now you're postmenopause for the rest of your life. Does that make sense, Miriam?
It does.
Yeah. Okay, good. So let's move on.
Does anybody have questions about that? Just pop them in the chat if you do.
Yeah. Yeah. And I mean, Miriam will interrupt me if something comes up. So by all means, just ask away. Okay, so let's talk about perimenopause in particular. So as we talked about, it's that 5 to 15 years before menopause. And this is a period of time where your sex hormones are declining, but it's not like it's like a consistent ramp down. Okay, and that's the thing. There is fluctuations, and I'm going to show you a graph in a moment that really shows you those fluctuations. The two hormones we're going to discuss are progesterone and estradiol. And estradiol is a type of estrogen. So if it's easier for you, just think estrogen when I say estradiol, okay? Now, during this perimenopause time, you may notice changes in your menstrual cycle. They may become shorter or they may become longer. They may become irregular. They may be heavier. They may be lighter. You might experience more cramping. Now, also, a normal part of perimenopause is cycles where we do not ovulate. Okay. And we're going to go over what that means to ovulate. Okay. And it's not just about being able to have a baby or, being able to conceive. There's more to it than that. Okay. So this is a graph that's looking at estradiol or estrogen and progesterone through the lifespan. Okay, so we're going to start off in childhood. And what I want you to notice is both estradiol in kind of that reddy pinky color and progesterone in that blue color, they're both kind of at like a lower level, right? And then as we go into the teen years, you can see they're starting to ramp up, but it's not like a perfect and they're both not ramping up at the same time period, right? So do you think that might have anything to do with kind of what life is like in your teen years, Miriam? Like a little
Yes.
tumultuous, right? And, we can kind of see that tumultuousness in the graph here, right? Just with what the hormones are doing, okay? Then you reach kind of what they're terming your reproductive years. And you'll see that like there is a more consistent up and down there. You can see of the progesterone. Notice it's not just a straight lower level, like there is this up and down and they're supposed to be. And you're going to find out why in a moment. And then the estradiol, like, there's some blips, but it's not as big. Okay. Now we move into perimenopause. And I don't know about you, but this looks even more erratic than the teen years. Does it not?
It does.
Yeah. And so this is why sometimes perimenopause is called the second puberty. Okay. And right now, and it's a time, where you've got kids too, some of them in puberty. So isn't that wonderful? Right. Okay. So I want you to see how the progesterone kind of drops off faster than the estradiol, okay? And the estradiol, like I say, it's kind of up and down. Like there isn't just this consistent going down. Like it's kind of all over the place there. But then you get into menopause and everything just kind of starts to level out. And then your body can kind of catch up. Okay, this is now my resting state. This is where I am. Does that make sense?
Absolutely.
Yeah. Okay. So moving on to talk about ovulation. So I think that most of us understand. So if we look at our menstrual cycle, so if we talk the beginning of the menstrual cycle, day 1 is the first day of your period. And then about halfway through the cycle is where you ovulate or you release an egg. Okay. So the release of the egg from the ovary into the fallopian tube. This is obviously essential for conception. But it's also an essential process to produce and release progesterone. Okay. And this is what I find fascinating. So ovulation leads to the production of the corpus luteum. That is a transient endocrine gland that produces progesterone. So we're talking every month we make an endocrine gland that then releases progesterone. Okay. As long as we're ovulating, right? So you have a month that's anovulatory. You don't release an egg. You're not going to produce that corpus luteum. You're going to have less progesterone. Do you think that's going to have an effect on you in some way? What do you think, Miriam?
It has to.
It has to. Exactly. Yes. Now, what I want to say is that during perimenopause, it is normal to have some anovulatory cycles. However, there's another condition that we need to talk about that kind of talks about ovulation. We're going to talk about that in a moment. So ovulatory cycle, this kind of shows you what's happened. So you can see at the beginning of a graph, that's day 1 of your period. And you'll see for the first half of your period, progesterone's kind of like at a consistent lower level. Then ovulation, and you get this big whoop, and it comes up because that's that corpus luteum, right? It's formed, it's releasing the progesterone. And you can see the estradiol, it has this initial coming up right before ovulation, comes back down, goes back up again. Anyway, they have these normal waves that this is exactly what we're expecting, okay? The time period before ovulation, we call that your follicular phase. The time period after ovulation, we call that your luteal phase, okay? Now, here's an anovulatory cycle. So there's no ovulation that took place here. I want you to take a look at progesterone. It's kind of flatlined, right? So yeah, that's definitely going to have an effect, right? The estradiol, there's still going to be some up and down, but even it is not the same. But the starkest difference is in the progesterone levels, because you're not going to see the big increase that you normally would, right? Okay. Okay. Now I said that there was another condition that can lead to anovulatory cycles, meaning you don't ovulate, you don't produce that corpus luteum, you don't release that progesterone. So this is called RED-S, relative energy deficiency in sport, okay? And it's the result of insufficient caloric intake and potentially combined with excessive energy expenditure. Now, Miriam, you can see that there's like a graphic. You can see my arrow here, right?
Yep.
Yeah. Okay. So back when I was a baby physio, we didn't have RED-S, but what we did have was the female athlete triad. Do you remember that, Miriam?
Yep, absolutely.
Yeah. So in the red here, we had, I think they called it like disordered eating or eating disorder. And we had like the changes in menstrual function. In fact, I believe they were just very clear that it was amenorrhea. So you stopped having a period, right? And then in the bone health section, it was, they either weren't reaching their peak bone mass, or their peak bone mass was lower, or they were starting to see low bone mass at a young age, right? And we were typically talking about like young athletes, right? Young female athletes.
Yeah.
As you can see, we have a much broader understanding of how this relative energy deficiency can affect all of our body systems. Like, it's huge, right? It can affect your immune system, your gastrointestinal, your cardiovascular, your psychological, your growth, development, your hematological, your metabolic system, your endocrine system. Like, this is big. And like I say, when I was a baby physio, we talked about this in relation to like teen women and women, like say in university sports. So we're talking a lot about teens and in their 20s, right? We are seeing this in midlife women. Okay. Yes, it's happening at the earlier stages, but we are also seeing this in midlife women. Miriam, can you have a sense of what could be driving that? It was something that you
Well,
mentioned earlier back in the fear stage.
oh, as far as the weight gain,
Yes.
because people are thinking, oh, I'm eating too much. And so they start to change how they eat, and then they exercise more and exercise harder, and drives this whole process. Absolutely.
Yes. Yes. So yes, this is very much comes up for some women in midlife. So like I said, when I was a baby physio, we were talking about this with teens and girls in their 20s and just talking about these three areas. Now we understand that it has more broader implications for our health and that it's not just younger women. We as people in our perimenopause or even like menopause, we need to be aware of this as well. Now, I want to show you the signs and symptoms of red S. Now, what I've done here, you can see that there's some that are in purple, right? You can see that, right, Miriam?
Yep.
So the ones in purple are the ones that are common in both red S and in perimenopause. So you can see how if you are in that red S state, how it could be amplifying perimenopause symptoms, right? And it would be hard to tease out, right?
Mm-hmm.
You wouldn't necessarily understand that that red S could actually be making things worse in terms of what you're experiencing and just thinking, oh, this is perimenopause, okay? So when we get to the action plan, we'll talk about this a little bit more so that, we understand that we are fueling ourselves well and that we are, exercising well but avoiding this relative energy deficiency state. Does that make sense?
Yep.
Okay.
Yep.
So let's move into postmenopause now. Okay. So if you remember back to that graph, we saw that, before the teen years, it was kind of low. And then in the teen years, it started to fluctuate. And then we got up to what they were calling our reproductive years. And it was like kind of a consistent up and down, right? And then we went through the tumultuous kind of craziness of perimenopause. Now in menopause, we're getting to more of a constant low level state of estrogen and progesterone. Okay. Now, hormones influence everything. Pretty much every tissue in our body has hormone receptors. Okay. Now, what I want to say is that in postmenopause, you don't stop producing estrogen completely, but the type of estrogen that you produce the most does change. So the type of estrogen you produce then is called estrone. That's what's in the highest quantity. And it's a weaker form of estrogen compared to estradiol. Now, as I said, estrogen can affect many areas of your health, your muscles, your tendons, your connective tissues, bones, brain health, mental health, cognition. That's that what do you call it? That brain fog that I'm having right now. Metabolic,
Loss, all of those things.
cardiovascular, pelvic health, you name it. Okay. Now, estrogen is anabolic. It's anti-inflammatory. It actually makes it easier for you to recover from injury. So, there is a reason why younger people do tend to recover a little bit more easier. It helps to increase power. It actually increases the efficacy of the actin-myosin coupling that is needed for muscle contraction, which that's fascinating, right? I think it is.
Yeah. Yeah.
So in terms of muscles, estrogen improves muscle mass and improves strength, power. For the tendons, it increases the collagen content of the connective tissue, so that improves the tensile strength of your tendon. In terms of cartilage, it decreases the degradation of type 2 cartilage. Type 2 cartilage is the main type of, type 2 collagen, pardon me. Type 2 collagen is the main type of collagen found in cartilage. Guess what? this may have implications in osteoarthritis. And they're looking at other ways of preventing osteoarthritis through this understanding of estrogen, especially in this perimenopause and early postmenopause time period, which is going to be fascinating to kind of see how.
Yeah, that is very fascinating for sure.
It's going to mean earlier preventative treatment is going to be the way to go. Now let's talk about muscles in postmenopause. So we know that estrogen declines, right? And so we know it is going to be harder to put on muscle mass, not impossible, but just not as easy as it was when you were in your 20s. And we know that power declines. We know that you are now at risk for something called sarcopenia. And sarcopenia is a condition of low muscle strength, low muscle quantity or quality, and low physical performance. It is associated with low estrogen states and with the aging process, okay? It tends to start, and it's going to be variable for different people, but it tends to start in perimenopause when that estradiol is starting to decline, okay? So I want you to remember this, because perimenopause, it turns out, is the prime time to really look at what you're doing physical activity wise, to have a real impact on essentially this aging process, right? A real impact on your health for years to come. You look like you have something to say there, Miriam.
No, other than I wish
in.
all of this was, much more well-researched, 15 years ago when I was in my 40s.
Right. And so this is where, like, for the people who are out there, they're in their 40s, like, grasp onto this. I understand that hearing these changes can be like, well, geez, what could I possibly do then? But there is so much you can do. And so I want you to remember.
Absolutely.
Okay, let's talk about the tendons in postmenopause. So again, tendons have estrogen receptors. Estrogen actually decreases the stiffness of tendons too. Our tendons are much more resilient when they have an abundant supply of estrogen. They love estrogen and they hate change, kind of like me. I get you, tendon. So tendon pain in postmenopause tends to be associated with a change in activity or exercise. Maybe you've taken up a new sport or new exercise and you've gone really gung-ho at it. You haven't kind of gradually gone into it. The tendons potentially may say, nope, this isn't going to work for me. Primary sites of tendon problems or tendinopathies in midlife, we see the shoulder, the hip, the feet, the ankles, elbows, knee, the thumb. Those are really common areas of tendinopathy, especially like in that early postmenopause period. So we're talking like in the 50s, right? Typically, right, Miriam? That's where we're.
Yeah. And I think you're going to get to this answering this next question, but somebody's asking, is there anything that can be done to reverse this in postmenopause?
Oh, and I would
talk about these. I think we're talking about the sarcopenia and the strength changes.
Yes. Okay, so absolutely there are things you can do. Yes, and I do promise that we are going to get to that, and I'm really glad that you're grasping onto that, because that's important. That's important that we focus on controlling our controllables, and we're going to get to that. Thank you. Okay, now I would love to talk about each of these areas of the body and kind of talk about more in depth about what happens at each area. I've just pulled one because of time. Okay, so I've pulled out, it's not, there we go. I've gone too far. There we go. I've pulled out the shoulder, the 50-year-old shoulder. That's actually in the research. Oftentimes they will use that phrase, right? They will use the phrase, the 50-year-old shoulder.
That's hilarious.
Right? But we see it clinically, right? So
we do, absolutely.
There does tend to be an increase in risk of shoulder dysfunction in midlife women. Now, we know that low estrogen, those tendons really miss it, right? Now, some of the other things that can contribute to shoulder dysfunction there, that 50-year-old shoulder, stress, especially stress that is kind of unmitigated. Like you don't complete the stress cycle. And we're going to talk about that in a minute, because I am not advocating for you to live in a state of Zen, right? You know, where we're not just going to spend the rest of our lives in meditation. That's not it. But there are ways that we can mitigate stress, okay? Sleep interruption, blood sugar or metabolic issues. Now, here's the thing, and we aren't really going into the metabolic changes with menopause in this webinar, but lower estrogen does lead to more risk of insulin resistance. Okay, and that's what is seen in type 2 diabetes, right? So with this insulin resistance and these higher blood glucose levels, you can create what's called these advanced glycation end products. And that has actually been linked to shoulder tendon problems in midlife. Okay. Starting a newer activity, and like I say, just going really gung-ho at it, you know, without the body having time to adapt to it. So these are some of the things that can exacerbate shoulder pain in midlife. Did you have anything you want to add there, Miriam?
Nope, that's good.
Good. Okay. Now, bones. Okay, so again, we're talking post-menopause. So we're in that decreased estradiol or decreased estrogen state. So there's actually two phases of bone loss in this postmenopausal state. The first phase, the decreased estrogen leads to increased bone resorption. That means bone that's already there is actually being resorbed, okay? So during the menopause transition, the average reduction in bone mineral density is 10%. That's talking about that 5 to 6 year time, like right around menopause itself, okay? So that is the fastest period of bone loss typically in a woman's life. Now, 50% of women actually tend to lose bone more quickly for whatever reason. They can lose up to 20% of their bone mineral density in those 5 to 6 years around menopause. And I don't know about you, Miriam, but sometimes I'll get women that are coming to me, say early in their 50s, and they've just had their first bone mineral density test, and they're shocked.
Yeah.
Right?
Yep, just actually fairly recently. Yeah, somebody who was just because they've been active their whole life, but all of a sudden, yeah, they've got low bone density.
Yeah. So yeah, I've had several in the past couple of months where they either have low bone mass on their report or they actually have osteoporosis and they're in their early 50s. Okay. And again, all of them saying, but I drank all the milk and I did all the exercise. What else is going on here? What could I have had control over here? Okay. And we are going to talk about that a little bit more. So the second phase of bone loss is after that first 48 years, then it moves into more of a persistent, slower loss attributed to reduced bone formation. So do you see what's happening here? So it's that first 5 to 6 years, there's actually increased bone resorption, but then we move into a state of reduced bone formation. So at this stage, is there something that we could do that may actually promote bone formation? And the spoiler alert is yes, absolutely. And this is where really a whole osteoporosis presentation would just be wonderful, right? But yes, there's absolutely things.
Which we have on the website. If you're looking for that, if you check out the fit to the bone webinar on the website, goes into all of that.
Perfect. Great. Okay. Now, pelvic health, this is my love, and I would have loved to have done the whole presentation just on pelvic health alone, but I was trying to be a little bit broader and to bring you in, but let me bring you into my world now. So the lower urinary tract, the pelvic floor muscles, the genitals, and all the supporting tissues of the pelvic floor are estrogen receptive, meaning they are affected by your estrogen levels. So estrogen helps support the maintenance of an acidic vaginal pH. That's a good thing. We want our vaginal pH to be acidic between 4 to 4.5. Estrogen supports the structure of the urethra. it actually raises the bladder sensory threshold. So, you'll be able to hold more urine before you actually get a signal like, oh, we're getting full, I need to go to the bathroom. Okay. And it promotes detrusor relaxation. Now, what's the detrusor? The detrusor is the muscle that actually surrounds the entire bladder. And so if that muscle is, a little bit more active, maybe overactive, you're going to be getting those signals. Oh, I got to go. Oh, but I just went 10 minutes ago and I got to go again. Okay. But with estrogen, it promotes, like I say, that relaxation of it. So less of that urgency, frequency, right? Now, estrogen also supports the tissues that support our pelvic organs, so like our bladder, our uterus. It helps to promote or support pelvic floor muscle mass and strength. And you're going to hate me for this. It actually helps the passive urethral closure mechanism. It allows for that urethra to remain moist. And I know I'm not allowed to say that word, but I just can't think of another word to put there. So there we go. It allows it to remain moist. And that moistness, I don't know if you can remember from science class, but that actually helps to create increased surface tension. And it just helps to keep the closure there. When it's drier, it's more likely to open, and then you can get more passive leakage of urine. Okay, so there we go. So again, still talking pelvic health and postmenopause. This is a term that I really wonder how many people have heard. Okay. And I would actually love, if anyone out there has heard this term before, I would love for you to say something in the chat, because I want to know actually where you've heard it from. So GSM, genitourinary syndrome of menopause. Now, this is the term that I believe it was in 2014 that they replaced vaginal atrophy with. And really the term vaginal atrophy, I mean, it didn't describe everything that was going on. And it's just, I don't know, it's not a great term. So now they've kind of broadened it, and they're using the term GSM, or genitourinary syndrome of menopause. Had you heard that term before, Miriam?
I actually haven't, no.
Yeah. So this is what I mean. Like, this is like newer that not many people know about. So let's talk about what it actually is. So we know we're in a lower estrogen state, but one thing we haven't talked about at all in this webinar is that we're in a lower testosterone state as well. So the changes with GSM are hormonally driven. And so they affect the vulva, the vagina, the bladder, and the urinary system. It can decrease the length and the width of your actual vaginal opening, and can thin the tissues kind of throughout the vulva. Now, if we're talking about the vulva, you know how we have like the outer lips, the labia majora, and then we have like the inner lips, the labia minora? That labia minora starts to shrink or resorb, and in some cases can completely resorb. Okay. Yeah. With less estrogen, decreased bladder elasticity, that can lead to that increased urinary urgency, frequency, decreased passive urethral closure, so less moist, right? So you just don't get that nice surface tension, passive closure mechanism. Your vaginal pH may increase, and so that can actually lead to an increased risk of UTIs, yeast infections. Vaginal dryness, that's actually a very common one. And that's one that sometimes people will tell me, well, yes, I have vaginal dryness, but I'm not actually sexually active right now, so it's not bothering me. And what I say to that is, that's one symptom that there's changes going on here. And that may be your only symptom now, but it's kind of the canary in the coal mine. It's letting you know there's changes here, and we should do something before things progress, right? If you want to prevent problems, right? Yeah.
Absolutely.
So it can actually even be this vaginal dryness or irritation. It can be a barrier to exercise, because for some women, like, there's actual chafing that can happen with it. Now, decreased strength of the pelvic floor, connective tissue. So those connective tissues that support the pelvic organs. The person may have painful intercourse or painful any form of penetration. And this tends to happen, or it tends to start in the first 1 to 7 years after menopause. Once we're 10 years into postmenopause, 50 to 60% of women will have some symptoms, right? And then, of course, that's going to increase as we go along. Is there things you can do here? Yes, yes, yes. Okay. And I promise you we're getting to that. Any questions before I move on there, Miriam?
I haven't seen any new questions. Anybody have any questions they want to pop up before we move on?
Oh, that's okay. You can interrupt me.
I
if
will.
something-
Yep.
Okay. So action plan. Oh, it's blank. I guess we're done here. Sorry, no, there's nothing. I'm kidding. Of course, there's something you can do. So what can you do? You can control your controllables. And I have to put a shout out to Michelle Lyons here. She's a pelvic health physiotherapist in Ireland. And like, this is her phrase, control your controllables. And you'll see what I mean in a moment here.
That's a good phrase.
It's a fantastic phrase, right?
Yeah. Yeah.
Okay. So, and this is a good one too. This is a good quote. When women take care of their health, they become their own best friend. Dr. Maya Angelou. I mean, there's so much in there. And yes, that is exactly what we're going to be talking about next, how we take care of our health. So let's start with what not to do, or let's start with what not to do on a consistent basis, because we're not talking about perfection here either. I don't think perfection serves any of us well. Let's like an 80-20, right? 80% of the time we're doing the things we know serve us well. And maybe 20% of the time there's just things that we choose to do because maybe it's just what we want to do, or maybe it just supports us in other ways. But let's talk about what an inflammatory lifestyle is and why that's a problem. So, a lifestyle where you have disrupted sleep, or maybe you just have minimal sleep. Okay, you're not getting enough. Increased stress where you're not completing the stress cycle. Because like we talked about before, some stress, maybe there are ways we can remove that from our life, but there are other stresses where there's going to be no way to remove it from our life, right? It's just going to be a part of our life, but we need to learn how to be resilient in the face of that and how to move through the stress cycle. A diet that's high in sugar, alcohol, and or processed foods. And I know this is not going to be popular. The Canadian guidelines changed on alcohol in the past few months, right? And what they're saying is that the lowest risk to your health is 2 drinks or less per week. And that, it goes up the more alcohol you have after that. Okay, that's kind of where the evidence is right now. And low physical activity level. So sleep, stress, nutrition, and activity level. I would argue that for the most part, these are all areas that we can work on. Okay, these are all areas that are potentially, with supports, within our control. Does that make sense, Miriam?
It absolutely does.
Okay. So an inflammatory lifestyle can stimulate a pro-inflammatory state throughout the body. And that is just not going to set you up well for a good rest of your life post-menopause experience. Okay. So let's talk about an anti-inflammatory lifestyle. Let's talk about this low-hanging fruit here. Okay. So adequate sleep. We know from the Canadian 24-hour movement guidelines that for adults aged 18 to 65, the research supports 7 to 9 hours of sleep per night for adults. Okay. Now, when it comes to stress, so effective stress management strategies. And so there's a whole array of things that you could do here. And we're going to talk later about different supports that you can look to add to your support team to kind of help you here if that's somewhere that you need help. but self-compassion is big. And we talked about that at the beginning, right, Miriam? That one of the reason I was doing this and giving the education is to foster self-compassion. Mindfulness has excellent research. Breathing practices have excellent research. Completing the stress cycle. And I just want to give a shout out to a book called Burnout, The Secret to Unlocking the Stress Cycle. Fantastic book. And the way they define the stress cycle is the moment at which our bodies learn that after facing danger, we are now safe, the completion of the full circle of stress. So that's what I mean by completing that stress cycle. Okay. And it is not, that doesn't happen through numbing. So that doesn't happen through me scrolling Instagram and Facebook, you know. Unfortunately, there is a process that we need to be a little bit more deliberate to help complete that stress cycle. Now, the other pieces here, so we've got the sleep, the stress management, optimizing nutrition. Now, honestly, the diet that has the most research and the most good quality research supporting it is the Mediterranean diet. And that's something that I would encourage you to look up if that's something unfamiliar to you, but you really can't go wrong there. Like, that is the most well-supported one out there. Choosing whole foods where possible, and taking a look at your protein intake, especially when we're talking about that sarcopenia. And someone was asking about that earlier, right? Like, can we do anything about this? Adequate protein intake is going to be really important here. Okay. Regular physical activity. And I wrote nothing next to that because we're going to talk about it in the next slide. Okay. So the Canadian 24-hour movement guidelines, they have different guidelines set up for different age groups, and they have it set up even for different conditions. So like during pregnancy, for like Parkinson's disease, for, I think there was one for MS, but there's a few different versions of these guidelines. I've pulled the ones for adults age 18 to 64 because I thought that that would encompass most of the people that are probably on this call today. So let's talk about physical activity. So moderate to vigorous aerobic physical activities such that there's an accumulation of at least 150 minutes per week. Now, the number sounds big at first, right? But if you break it down, that's 5 30-minute walks a week, right?
Mm-hmm.
And I mean, the way that, you know, that this is kind of best done is if it is kind of shared throughout the week. Now, of course, you can do more. This is an at least. So if you say, well, you know, I go for a 2-hour walk or hike on the weekend, that's great. Keep doing that. But we still want to have some of that aerobic physical activity spread through the week. Yeah. Muscle strengthening. So what is recommended is that muscle strengthening activities using major muscle groups at least twice a week. So that's kind of the minimal guideline. Okay. Now, if you already have low bone mass, or you know you're at risk of low bone mass, or you already have osteoporosis, the Osteoporosis Society is going to tell you 3 times a week. Okay. And like I said, this twice a week, that's the minimum. 3 times a week would probably be great as well, especially with rest breaks in between, right? So we're not doing those 3 days in a row. We're separating things out there. Was there anything you wanted to add there, Miriam?
No, other than I think that is probably one of the most important things that I think women our age need to be including into their exercise program, almost more important than the walking.
I completely agree with you there. And especially when we're talking about that sarcopenia piece that was questioned earlier. I think that when we hit midlife, that it's no longer an option whether or not we participate in some form of muscle strengthening. I think it really does become essential. It becomes, you know, it becomes as essential as washing your hands. Do you know what I mean? If you want to set yourself up well, like to age well and to have a good quality of life. Okay. So it's non-negotiable.
Yeah.
And I know as soon as I say that, someone's going to say, well, I'm not going to do it.
But it
And
doesn't have to,
I
it
get
doesn't
that.
have to look like a big, huge, long workout program either.
Yes, exactly. There's a lot you could get done in a 20, right? 3 times a week. Is that us dying?
No,
Computer?
sorry. No, that was a call coming into my computer.
Oh,
No.
okay. So also for the physical activity guidelines, they also suggest several hours of light physical activities, including standing. And I did want to say here, because this is a menopause presentation, that there was a recent research study that found strength training 3 times a week, and it was like a full body program. I think there were 8 exercises, reduced hot flashes by 44%. Like,
Pretty
come on,
significant.
that's fantastic, right?
Yeah.
Yeah. Okay. So now, still the same guidelines. If we look at sleep, so like we said before, recommending 7 to 9 hours of
Can I
good.
interrupt for 1 second? There was a couple questions that I missed. I didn't scroll down far enough. Someone was asking, is walking considered an aerobic exercise? And someone was asking about some examples of strength training other than weights.
Oh yeah, so like body weight. Well, and this is very interesting that because there is a lot of, things that are, say, in like yoga and Pilates that have a strength component to it.
Yeah.
And say like doing a squat, you can do a body weight squat that is strength training. You could do a wall push-up that is strength training. Like that requires like no like additional weights. Is that what you're meaning? Like no like dumbbells?
I think that's what they're meaning. Yeah.
Yeah,
Yeah.
so there's
And it-
plenty of body weight ways.
Yeah. And I think everyone needs to start with where they're at. Like it doesn't, some people shouldn't necessarily start with adding weights in because they might need to start with body weight because that's the level of where they're at as far as strength is concerned.
When we talked about how the tendons, they don't like you going too hard too fast, right?
Exactly.
Especially if they're already in a lower estrogen state. So yeah, I don't want to encourage you to say, okay, I'm going to hit it hard in the gym now, but I haven't actually been to the gym in 10 years. Yeah, no, it might be that body weight.
You might then run into some problems if you jump into things too quickly.
Yeah. Yeah. All right, let me go back to here. Oh, let's see. Oh, there we go. And I think it's going to shoot me forward too many, isn't it? Okay, there we go. Sleep. Yeah, so we're talking about sleep, 7 to 9 hours, good quality sleep on a regular basis, consistent bedtimes and wake up times for the most part. I know there's going to be times where that's not possible or just not what you want to do, but we're talking about that 80-20 rule again, right? So sedentary behaviors, we want to limit sedentary behaviors to 8 hours or less. So breaking up long periods of sitting as often as possible and trying to limit recreational screen time to 3 hours a day. Okay. Now, I want to talk about this just a little bit. Okay, menopause hormone therapy. It was previously called hormone replacement therapy or HRT, but the terminology is changing there and they're calling it menopause hormone therapy. There are 2 options really. There is systemic and there's local. Okay, when we talk about local, we're typically talking about in the pelvis, like in the pelvic floor. So you can actually get creams that you may put topically on the pelvic floor, like the vulva and into the vagina, or you may get ones that are little tablets that you insert vaginally. That's local estrogen therapy. That does not go systemic. That is the kind that is typically safe for most people, but obviously something you talk to your doctor about or your naturopathic doctor about, but that is the one that tends to be tolerated by most people. Systemic, there can definitely be a role there. I mean, absolutely, you're going to be talking to your healthcare practitioner about it, but I wanted to bring to you the North American Menopause Society recommendations, and I'm a member of the North American Menopause Society. So they're located in the US, so they're going to talk about the FDA. So menopause hormone therapy is FDA approved for 4 indications currently. For moderate to severe vasomotor symptoms. So vasomotor symptoms are like your hot flashes, your night sweats. Prevention of osteoporosis in postmenopausal women. Okay, we have plenty of evidence that it is effective for that. And we talked about the different phases of bone changes in postmenopause. So we can see how the addition of that estrogen might be helpful there. Treatment of hypoestrogenism caused by hypogonadism, bilateral oophorectomy, that's when you remove the ovaries, or primary ovarian insufficiency, and also the treatment of moderate to severe vulvovaginal symptoms. And they speak specifically to the genitourinary symptoms and how the low-dose topical vaginal estrogen has level 1 evidence. So when women come to me in midlife, especially if they're coming to me for pelvic health concerns, I will ask them, have you ever had a conversation with your doctor about topical, low-dose, local vaginal estrogen? And some of them will say, yeah, I'm on that already, or no, I've never even heard of that. My doctor's never brought it up. I've actually never told them about these symptoms I'm having. So I will encourage them to have that conversation. It's obviously not something you're going to a physiotherapist to get a prescription for, but I do take my role as educating on what's available and what would be a good idea to talk to your other healthcare practitioners about. Okay. Is that fair, Miriam?
Yep,
Okay.
absolutely.
Good. Okay. There we go. So getting your support system together so that you can thrive in menopause. Questions you need to ask yourself, like, where do you need help? Like, what is it that you need? What are your current concerns right now? And what future concerns do you have? Like, I know I may have current concerns like kind of regarding my strength, but I also have some future concerns about my bone mineral density. I know that, that there's risk there. Who is the best person or professional to help you with each of your concerns? Okay, so depending on what your concern is, you may be going to a different professional. If you had a question about nutrition, who are you going to go to for nutrition advice? Okay, are you going to potentially talk to your family doctor, or are you going to go see a registered dietitian? Maybe you're going to see a naturopathic doctor. Maybe you're going to see someone who has more advanced training in nutrition, especially someone with training in midlife nutrition, right? Maybe you need support from a sleep coach, right? Maybe sleep is your real issue and you've tried all the sleep hygiene hacks and nothing's working for you there. Maybe you need a sleep coach. Maybe you need some cognitive behavioral therapy that has some great evidence to help you there. Maybe you're having problems with your shoulder or your hip right at midlife. Maybe seeing a physiotherapist is where you want to go. Maybe you need a kinesiologist. Like, there's lots of options there, and your circle of support is going to look different from someone else's because it's going to be tailored to what you need, right? Any thoughts there, Miriam?
Yeah, no, that's a great list for sure. Because all of those areas, I think we can all use some direction in.
Yeah, yeah. Well, and I think like it really comes down to, and this isn't an exhaustive list by all means. It's you really have to identify for yourself, like, where am I struggling? Like, I know that I have to be mindful of my sleep. I know I have to be mindful of my stress. I know I have to be watching my nutrition. I have to be looking at my physical activity. Where are those kind of 4 key areas, those 4 pillars of health, am I struggling the most in? And I will tell you that even as a physiotherapist, my naturopathic doctor told me, you know what, Wendy, I think you should get a fitness coach. And I thought, what? What do I need a fitness coach for? I'm a physio. I was a kinesiologist. Heck, I was a fitness instructor. I don't need a fitness coach. It turns out I needed a fitness coach. So I got myself a fitness coach, and it's definitely been the right person to add to my team. But you have to figure out where your goals are, like where your needs are.
Where you see yourself when you're in your 60s and 70s and how you want to live your life, right? In your 40s and 50s is the time to address that and get you to the point where you're living the life that you imagine.
Exactly. There it is. All right. Now, are there any other questions? Are there any that we missed, or did we get to all the ones that are already there?
I don't see any other questions that we've missed, but does anybody else have any further questions that they just pop it into the chat or into the question answer box? And certainly if you think of questions after, then please pop us an email and we can certainly answer your questions at a later date. There, thank you, Wendy. Yes. And Wendy will be able to direct you to whether she can provide the answer or direct you to sort of the appropriate professional that can give you the right information. Oh, we might have had another question in here. Oh, thank you. Oh, you're quite welcome.
Oh, thank you.
It's been great listening to you, Wendy. You're always such a wealth of knowledge. So definitely
Honestly.
appreciate taking the time to present this information because it is so important. You know, there's so many women who are dealing with these changes, and I think it's only been in the last number of years that the information is actually now becoming more available and more understood. So we need to get that information out there. Absolutely.
Well, and I think that women are starting to demand more of their healthcare.
Yes.
And they're starting to be more willing to bring these concerns to their healthcare providers, to their doctors. And I want to say that, especially if you're wondering, is hormone replacement therapy or is menopause hormone therapy right for me? You are probably going to be the one that has to broach that with your doctor. Yeah. They won't necessarily bring it up. So, you know, I really want to encourage people to, or empower people to advocate for themselves and to bring these questions forward.
Absolutely. Yeah. And somebody had just commented that they wish they had the information 10 years ago. And absolutely, I feel the same way, but I think it is never too late. It is never too late to make some changes and have a positive impact on your health and how you feel. Absolutely. So, but you do need to start asking questions and as Wendy said, just advocate for yourself.
Mm-hmm, mm-hmm. Are there any other questions there? I can see the number, but I don't see the questions.
Okay, just a thank you for the presentation. Yes.
You're welcome.
Yes. Okay. All right. Okay, well, everyone, it always seems so strange to say goodbye when I can't see people's faces in front of me, but I hope everybody has a nice evening. And again, if there are any further questions, please let us know. We do have some more upcoming webinars towards the end of the month. On the 26th, I'm offering a webinar on running and preventing injuries. Find your stride, how to prevent running injuries. And then a week later, mobility and strength for runners. And then in May, Leslie will be presenting Fit to Garden to keep ourselves healthy and well as we garden. So if you're interested in any of those webinars, just hop on the website and you can register there.
Awesome.
All right. Okay. Have a great night, everybody.
Take care. Bye.